Good evening, good morning, good afternoon, everyone, wherever you are in the world. Welcome to the GLODAM webinar for this month. And the topic for the month is Skin NTDs. And our presenters today are Prof. Enbiale and Dr. Olufolakemi. We'll go into their bios shortly. My name is Dr. Karen Waithera. I'm from Kenya. So just some housekeeping rules before we start the webinar. So our meeting hosts today are myself, Karen Waithera, and we have Dr. Sibali Gibu and Dr. Stembiso Mlanga. So GLODAM, who are we? The GLODAM Training Committee is part of the International Alliance for Global Health Dermatology as part of the International Foundation for Dermatology, the IFD. We promote knowledge equity by improving access to education for dermatology trainees across the world. We aim to provide free educational events and opportunities to build networks and to collaborate. So as part of our meeting etiquette today, your audio will be muted and your camera will be turned off for the duration of the webinar. If you have any questions or comments, please submit them via the chat function or the Q&A button. Your meeting host will share this with the speakers to answer at the end of the webinar. We will also be sharing further information about the GLODAM Training Committee in the chat function. So some more information about our speakers today. Prof. Enbiale is a professor of dermatovenerology at Bahia Dar University. He has 20 years of experience in the field of dermatology and public health. And he also has specialist training in NTDs. We also have Dr. Olufolakemi. Sorry, that's a bit of a tongue twister for me. Our presenter, Dr. Olufolakemi, is also well versed in the field of NTDs. She comes with a training in consultant dermatology and venereology, and she's from Lagos State University. So we'll go through the rest of the slides at the end of the webinar. Over to our presenters.
Good morning, and everybody, wherever you are. And our presentation today is going to be Skin Neglected Tropical Disease, perspective from the African dermatologist experience. And Dr. Olufolakemi is going to present especially her experience. But before she jumps into that, I'm going to set the scene by especially introducing the NTDs in general and specifically also the skin NTDs. Next. So the outline of our presentation is going to be just back. The outline of our presentation is going to be there will be an introduction of the NTDs in general and the skin NTDs, and then the global and regional prevalence of skin NTDs. Then Dr. Olive is going to take us to her experience and especially the overview of the skin NTDs. Next. Next. So when we think of the neglected tropical diseases in general, these are the heterogeneous group of conditions caused by a diverse pathogens that can be virus, bacteria, parasite, fungi, and toxins. But in general, those neglected tropical diseases, they are not only the disease of the tropics, but they can be also more, actually, they're represented by disease of the poor. And I'll talk later on about some other diseases, who are some of the diseases which can be presented also out of the tropics. So but most importantly, those diseases occur mainly in tropical countries, especially in Africa, Asia, and South America. And in around 149 countries, there are WHO reports around an estimation of around 1.7 billion people, and around 500 million children are affected by those general neglected tropical diseases. And most important thing here is those diseases affect dominantly the impoverished and marginalized population. And there is a saying, some say that actually it's not the disease which is neglected, but it's the people who are neglected. And as a result, they receive little attention in funding and researches, and that is associated with the devastating lifelong health, social, and economic consequences. To include those diseases into neglected tropical diseases in general, WHO has put around 4 criteria. And when you think of those 4 criteria, the first criteria is the disease has to be dominantly affecting the poor. Second is usually it's the in tropics. And third, there has to be a treatment or a management package. And the fourth is those diseases has to be also not on these of the neglected, but they have to be also neglected by the researchers. So these are the WHO 21 neglected tropical, the list of WHO 21 neglected tropical diseases, as you can see. And the one with the red highlights are the one which are presented primarily with skin NTDs. So half of the WHO, almost half of the WHO neglected tropical diseases can be present primarily with skin manifestations, but even the other 2/3 of WHO neglected tropical diseases, they have either primary or secondary manifestation in the skin. Next. Next. When you think of the skin NTDs in general, from these are a subset of the NTD from the WHO list, as you have seen, the red mark that present primarily with cutaneous manifestations. And many rural communities, skin-related NTDs can form about 10% of the skin diseases and often underreported or not in routine surveillance system. And severe negative impact, especially when it comes to quality of life of individuals, families, and communities. And most of the skin NTDs actually, they're not really fatal, but they can cause associated stigma, discrimination, and socio-economic problems. As you can see from those images, these are some of the skin neglected tropical diseases. You can see from cutaneous leishmaniasis, PKDL, tungiasis, scabies, leprosy, elephantiasis, podoconiosis, and so on. Next. So the prevalence of neglected tropical diseases and also especially specifically the global case of skin NTD is not really known. And the figure you are going to see here is from the small data which are either reported to WHO or from the data which is collected. So this is not really the actual figures. So when we think of, for example, the Brule ulcer, annually in 2020, there was 1,458 case reports to WHO. Leishmaniasis, there were around 270,000, 207,000 case reports. In leprosy, well, in the last almost decade, there are about 128 to 135,000 case reports annually. And even though WHO and most countries has reported control of leprosy, as you can see, the incidence of leprosy is almost for the last 10 years, from what you see from this figure, is more or less the same. Next. So the onchocerciasis also, usually the onchocerciasis, we have a proxy indicators, people who are living on onchocerciasis endemic area. Around 238 million people live on onchocerciasis endemic area. These are the area which needs at least a preventive chemotherapy. And lymphatic filariasis, the figure also goes the same. This is from the place which are really predisposed for lymphatic filariasis and which are amenable for preventive chemotherapies. Scabies, annually, there is an estimation of around 200 million people affected at any time during the year. Next. And when it comes to mycetoma, especially this mycetoma and other subcutaneous mycosis, the figure is really, there is no really much report to see. The largest number of cases being reported is from Sudan, but most countries are not reporting mycetoma or other fungal infection. And in the since the 1990s, there are around 10,000 cases reported in the WHO repository. The post-Kala-Azar dermal leishmaniasis mostly reported from either Southeast Asia and the East Africa. There are around 778 reporters in 2000. Yos disease, there are around 87,000 reported in 2000, but from this, the confirmed cases were only 346. Next. But when you see the prevalence of skin NTDs in Africa in general, there is really a few actual prevalence data, especially community-based studies. And most of the skin NTD papers or reports you see is either they are an individual skin diseases like scabies and leishmaniasis and so, or reporters, but there is no really integrated mapping of skin NTDs in the African setting. A recent movement to do an integrated mapping of skin NTDs, especially in West Africa, in rural Cote d'Ivoire from Yutsu, has shown 1% of the population and school children are affected by skin NTDs. And a study in urban rural Togo also, this is a community-based study, has shown 7.5% of the population are affected by skin NTDs. In the last 2 years, we tried to do some study in Ethiopia, both in northern and southern part of Africa, Ethiopia, and using some projects from WHO and for mycetoma, we tried to map the whole skin NTDs. In this unpublished study in the northern Ethiopia, we found that around 4.7% of the population of the community are affected by skin NTDs. In the northern part of Ethiopia, most of those skin NTDs are actually cutaneous leishmaniasis, followed by the scabies and then leprosy and mycetoma. But in the southern part of the country, the figure has shown that 21% of the population are affected by skin NTDs. This study has shown most of the skin NTDs are from scabies, followed by tungiasis and podoconiosis. And I'll leave now the floor to Olive. You can take that. And I'll say something about this. But in one study we did in a hospital-based skin NTD studies, this figure may be actually misleading because the hospital is providing as established as a leprosy hospital. So most of the patients who are coming to this hospital are either leprosy or other skin problems. And it's a sort of dermatologic hospital. It has shown that 17.2% of the patients have skin NTDs, and most of those patients, primarily it is either leprosy followed by scabies and then podoconiosis and mycetoma. Thank you. Ole, you can take that.
Okay, thank you so much, Prof. Wende. And my name is Dr. Olufolakemi. I'll be discussing on this webinar the clinical overview of skin NTDs. And as Prof. Wende has said, that skin NTDs are more of the diseases of neglected people and not neglected diseases, NTDs in general. So we'll be starting with leprosy, which is also known as Hansen's disease. And this is a chronic infectious granulomatous disease that usually involves the skin and the peripheral nerves, although also the upper respiratory tract and mucosa can be involved, and sometimes it can involve the eyes and cause blindness. And it's caused by the obligate acid-fast bacilli known as Mycobacterium leprae. Leprosy can be associated with permanent disability, And this is what is leads to the stigma and ostracization that is often associated with the disease. With the disease, leprosy, although in some clinical spectra, can often go undiagnosed or misdiagnosed. As we can see here, this is leprosy, and this is also leprosy at the lower border of the screen. And so this probably won't draw too much attention, but this definitely will. And sometimes people at this stage are, not diagnosed or misdiagnosed, and other people present with a different clinical spectrum, and of course end up with very severe disability like this. Now, there have been about 174,000 cases reported in 2022, and most of those cases were in Southeast Asia. A lot of countries have achieved elimination of leprosy, but there are still pockets of high prevalences in some parts of countries in Africa, like Ethiopia and Nigeria. So the diagnosis of leprosy is usually clinical, but laboratory services or the laboratory diagnosis are part of the diagnosis, but in many cases it may be difficult to have them done, particularly in rural setting. And that's the slit skin smear and microscopic detection of bacilli from that. But the three cardinal diagnostic criteria, leprosy, or the signs are, a definitive loss of sensation in a pale hypopigmented patch, like one that was seen there, or a reddish patch, and also two is a thickened and large peripheral nerve with sensation loss or weakness of the muscles of that nerve in the case of neural leprosy, and then of course the detection of bacilli and the slit skin smear. But however, this diagnosis this criteria may not be totally encompassing, because it doesn't really have the features of lepromatous leprosy captured in the diagnosis. And this may be one of the reasons why sometimes in our clinics, we see people walking with lepromatous leprosy. Unless a person has had prior dermatologic training, they may not be able to, based on this criteria, make a diagnosis of lepromatous leprosy. And I think that's something that, we probably need to look into. The slit skin smear also needs to be taken from about 6 places. And of course, skin biopsies and or PCR tests can also be done for leprosy where there's access. But again, access may be a challenge with some of those tests. This is an image showing how the slit skin smear is done. And then the different, this is a possibacillary slide, while this, you can see the red is a multibacillary slide. And if based on this diagnostic criteria, people may not be able to diagnose this as leprosy, and that's something that is food for thought, I think. Now, as I mentioned, leprosy has a very wide clinical spectrum, from the tuberculoid to the lepromatous. And tuberculoid leprosy usually occurs when there's an adequate immune response, while the lepromatous leprosy, where there is reduced cell-mediated immunity. And so and then there's a spectrum, there's borderline tuberculoid, borderline lepromatous, and then the mid-borderline, which is the Ridley-Joplin classification. The WHO, on the other hand, has 2 major classifications, possibacillary and multibacillary, based on the slit skin smear test, that is, and microscopy. So, but this is also, this is a lepromatous leprosy case. And also this, you can see the hypopigmented patches well here, and then the raised edges. But here, it may be difficult for someone who is not a dermatologist to be able to immediately think of leprosy with this, based on that criteria. Now, the treatment is the multi-drug therapy, which has been very successful at reducing the number of leprosy cases worldwide. And we are very thankful for that program. Sometimes we have challenges with access to care. Sorry. Now, as I've mentioned, the MDT has been very helpful and caused a massive reduction in cases, with 45 countries reporting 0 cases in 2022. But there are still challenges with leprosy, with the late presentation, as I mentioned, being able to diagnose lepromatous leprosy, and then people then, are undiagnosed until they develop severe disabilities. And of course, there may be clusters in some regions that have otherwise been thought to have been have eliminated leprosy. Now, drug availability also sometimes can be a challenge, and then the stigma often results in loss to follow-up. This is scabies now. So scabies is a parasitic infection caused by the Sarcoptes scabi mite, and it's characterized by intense pruritus and papular rashes in the groin, the interdigital webs, the wrists, the axilla. Those are the main places, but it can occur on any part of the body. It's the most common NTD seen in dermatology clinics across Africa, and almost all of us that practice in Africa can say there's no clinic that you won't come across a case of scabies. And in the communities, it's even it even has much higher prevalence in certain underserved or rural communities. The global prevalence is meant to be over 200 million cases, but this is probably an underestimate. And it's quite endemic in tropical countries and often associated with poverty and overcrowding. So the diagnosis of scabies is largely clinical. However, of course, skin scraping for microscopy or dermoscopy can be done. The clinical, there is a criteria for the diagnosis of scabies, but in resource-poor settings, usually the clinical picture of diffuse itching, which is worse at night with 2 visible lesions in, at least 2 typical locations with a household member itching, had very high sensitivity and specificity for scabies in a study done by Mahe and et al. in Senegal. So in many cases, this is how scabies is diagnosed. Dermoscopy is helpful to be able to identify the mite or the skybala, and that can be done where that is available. Now, the treatment of scabies is we treat infested persons and their close physical contact, whether they are symptomatic or not. And then the first line treatment is with permethrin, 5% permethrin cream. Also, benzyl benzoate is used in many settings, and in younger children or people with very sensitive skin, 5 to 10% of sulfur ointment is used. Oral ivermectin has also been shown to have very high efficacy after 2 doses of 200 micrograms per kg. So in many cases, ivermectin has been quite helpful. And a lot of studies have shown that mass drug administration for other NTDs like onchocerciasis with ivermectin has been helpful in, and also lymphatic filariasis has been helpful in the management of scabies in those communities. And it's important also to treat the fomites, the clothings, and the beddings when there's scabies, because sometimes the mite can live on there up to 2 days. So you want to also isolate them for 2 to 3 days as well. So in underserved communities, there is a high prevalence of scabies in such communities, and communities, we did some studies in places like Makoko in southwest Nigeria, which is an underserved area in the heart of Lagos. And we found it was more of a community outreach. In that community outreach, there was like up to 35% prevalence of scabies. In northeastern Ethiopia, a similar picture. And in prisons, recently I was in a prison in Lagos, and I was really overwhelmed by the number of scabies cases that were there. And also some rural communities have very high prevalence of scabies. So there is a need for mass drug administration in such communities, because otherwise they'll just be reservoir communities, and the problem of scabies will not go away. And it has, as anyone who has seen a patient with it, have a severe impact on quality of life, with sleep, with social stigma, because of the constant itching and scratching that occurs. Now, with onchocerciasis, that's another skin NTD that also affects both the eyes and the skin, and it's caused by the Onchocerca volvulus, a filarial nematode. It has a vector, which is the black fly, the Symbolium damnosum fly, and it's with the onchodermatitis, that's the skin manifestation. There's also severe pruritus, and various forms of dermatitis, which are listed there. They could present with an acute papular onchodermatitis, It could be chronic. There could be with light oncodermatitis, and there could be skin atrophy. Then also the oncocercal depigmentation, which is known as leopard skin, and there could be oncocercal nodules or oncocercoma. And of course, it also causes the visual impairment or visual loss called river blindness, which is the second most common cause of infectious blindness in the world after trachoma. This is a diagram of the life cycle, and it shows microfilarial worms being passed into the human, from the fly, and that's actually what the microfilarial worms, what causes it to a large extent the pathology. The adult worms just cause this cosmetic, and they just stay in the subcutaneous tissue and cause this cosmetic annoyance. But the main problem is with the microfilarial worms. Now, for the treatment and control of onchocerciasis, there's usually a skin snip for the microfilarial worm. There's some serological tests available also on the field, or PCR tests. And treatment often is with ivermectin, albendazole, or doxycycline, depending on the region, because in some areas you can't use ivermectin if there's also, I think, lower as well. So it depends on the region, but these are WHO recommended. But for the control, it's one of those NTDs where there's an annual mass drug administration is recommended with ivermectin, for up to 10 to 15 years in areas where it's endemic. Buruli ulcer is mostly found in West and Central Africa. This is caused by the mycobacteria. I'm not sure about the mode of transmission for Buruli ulcer, but we do know that it starts with, a nodule, which then progresses into an ulcer and can become quite severe and progress into bony involvement as well. It causes severe disability. Of course, you can see that there can be massive loss of cutaneous tissue, and there's no way that this will not heal without scarring and disability, without grafting, and it can be quite devastating. So it's one of those conditions that we prefer to catch very early to prevent, it's developing into these huge ulcers. But unfortunately, in many cases, that's how it presents. It can be diagnosed via PCR or histopathology, and it can be treated with rifampicin and clarithromycin. So early detection is critical, as we've said, and there needs to be a lot more research to understand the mode of transmission of Buruli ulcer, which maybe can help with control as well. Lymphatic filariasis is commonly known as elephantiasis, and it's caused by an infection with the filarial nematodes Wuchereria bancrofti in Africa and Asia, and Bugal malayi or Bugal timori in eastern parts of Eastern Asia. Most of the cases, however, are by the Wuchereria bancrofti filarial nematode, and all types of mosquitoes are vectors for this condition, and that's why it has a very wide distribution. Up to 850 million people worldwide are at risk of lymphatic filariasis, and it's actually a disease of the lymphatic vessel because the adult worms have a predilection for the lymphatic vessels, and they live there and cause blockage, which results in lymphedema and recurrent chronic lymphangitis and lifelong lymphedema. So with this, you characteristically see the unilateral swollen limb, which looks very, it's woody hard, and, it's quite characteristic. Treatment involves, MDA treatment, usually with albendazole, ivermectin, and diethylcarbazine, depending on the country. Also, doxycycline has also been included as part of the treatment, with them, because it's known to actually reduce the ability of the adult worm to produce microfilaria. So that also is included as part of treatment, but not on on an MDA basis, but on an individual basis for now. A very important aspect of treatment is morbidity management, and disability prevention. So because it's a chronic and lifelong condition, most times when the patients present, it's at an irreversible stage, and so you need to counsel them that, and try to prevent further progression of the disease. So even when you do treat and you cure, the elephantiasis or lymphedema does not resolve. So they need to learn how to manage it appropriately, keeping the leg affected limb clean, make sure they're using appropriate cleansers, moisturizers, and elevation also can help in some cases. And then if there are acute episodes of adenolymphangitis, which can occur, that needs to be treated acutely. In many cases of elephantiasis, there is involvement of the scrotal edema and hydrocele. And in such cases, surgical correction of the hydrocele can also be done. Now with podoconiosis, this is another type of elephantiasis, but it's called a non-filarial endemic non-filarial elephantiasis. And it's a type of tropical lymphedema, which usually is bilateral and ascending. So it's not caused by an infectious agent, but it's
Podoconiosis, as Ole has said, it is an endemic non-filarial elephantiasis. With the current existing evidence, the etiology of podoconiosis is not specifically known, but with the geographic distribution, the people who are affected, and also the epidemiology suggests that it may be caused by a soil particle, and usually it differs from lymphatic filariasis because podo starts from the lower leg and go up to, and usually limited below the knee. And currently, most of the podo patients, there are around 4 million podo patients estimated prevalence, and around 1 million of them lives in Ethiopia. And
yeah, and I'm so sorry for the network hitch. I just realized that I wasn't on the call anymore. Apologies, everyone. Yes, so I was discussing the podoconiosis. I'm sure Prof has discussed that as well. So we're at cutaneous leishmaniasis, which tends to be endemic in Northeast and Central Africa. We see quite a bit in the northern parts of Nigeria. My colleagues in northern Nigeria do see it quite often. We don't see it in our part of the country, except very, very occasionally. But it's known to be common in Sudan, in other parts of East Africa, and also North Africa as well. And, the cutaneous leishmaniasis is a bit different from visceral leishmaniasis, which is also seen in East Africa and Asia. There are different species, and the different species of subspecies of the leishmaniasis are responsible for cutaneous leishmaniasis, visceral, and then the mucocutaneous, which is more common in South Africa. The vector in the old world, in this part of the world, is the sandfly, phlebotomos. In the new world, we speak of the lutzomia, and also. But what we see generally is a skin nodule that progresses to a chronic ulcer. And like these photos show, usually it has a predilection for the exposed parts of the body, so tend to see it more on the face, on the limbs, on the upper arms and the lower limbs, and it can actually be quite disfiguring. In many cases of leishmaniasis, in some cases, very mild cases, it can go on its own. So you may not need to treat, you just observe, and then the ulcer disappears. So there's what we call watchful waiting. However, if it persists, then treatment may be instituted. In some cases, you may just start with intralesional injections of things like this thiogluconate. In some cases, oral azoles like fluconazole or itraconazole have been used, but the experience hasn't been so good with the use of these in most of the colleagues that manage cases of leishmaniasis. They don't really see too much improvement with that. In other cases, there could be cryotherapy or heat or electrocautery to destroy it if it's small enough. But of course, if it's extensive to this level, you may need to use systemic treatment in the management of that. Okay. I think the next slide, Prof, I think you're sharing now. Yes, so the post-color azole dermal leishmaniasis is another type of leishmaniasis that is commonly seen. Now, this form of leishmaniasis occurs with visceral leishmaniasis. So it's usually a sequelae of visceral leishmaniasis and can occur at any stage of visceral leishmaniasis. In many cases, it's said to occur with treatment, but it can occur even before treatment or during treatment. And it's quite endemic in Sudan, in Africa, and South Asia. In many cases, it's often, misdiagnosed as lepromatous leprosy, which can be a close differential. But as you can see, the clinical presentation of this condition, you could also think of so many other things like tinea versicolor, you could think of even vitiligo, and so treatment and clinical history is very important. I mean, diagnosis, and in many cases, it is infectious, and a histopathological section of the skin will show the Leishmania mastigotes, and so patients should be treated. And the treatment is the same as visceral leishmaniasis, usually involves systemic treatment. The next slide, please. Or should I go ahead and share? Yeah. Okay. So with Madura foot, this is, that one of the NTDs is deep mycosis, and deep mycosis include mycetoma or Madura foot, sporotrichosis, chromoblastosis, and Madura foot or mycetoma is one of the commonest forms of deep mycosis that we see as skin NTDs, which is caused by either the filamentous bacteria actinomycetoma or the eumycetoma, which is the fungal. We have fungal actinomycetoma and then the fungal eumycetoma as causes. In Africa, we see more of the eumycetoma than the actinomycetoma. However, in our clinic, the case reports that I'll show next was actually an actinomycetoma. It's common in tropics among farmers, people who walk barefoot, and people between ages of 20 to 40 who are more active outdoors. And the treatment, I mean, it can be quite severe and result in limb amputation. This chart shows the map of mycetoma globally, and you can see that it's across South America, Africa, and Asia. Next slide, please. So this was a case report of a patient who had Madura foot, who presented with this woody heart, multiple discharging sinuses, with neutrophil. So when we did the histopath, we wanted to see what we would find, and it was the characteristic splendor Hopley phenomenon that was observed, which made us think more of actinomycetoma. And can we go to the next slide, please? So we treated her with cotrimoxazole, gentamicin, and amikacin for 6 weeks. The edema was so intense, so we tried oral prednisolone, which was quite helpful initially and helps that. And then we followed up with oral doxycycline for 5 months. But she did have recurrence a couple of times. So the thing about mycetoma is that it can be very difficult to manage, and usually, they will need to have repeated treatment until it's under control. Next slide, please. So sporotrichosis, also part of the deep mycosis, which we discussed, which is caused by a fungus, dimorphic fungus called Sporotrix schenki, and it's also commonly known as Rose Gardner's disease. It's characterized by subcutaneous nodules along the lymphatic channel. So it's like a cutaneous porotrichosis. Initially can be reddish nodular papules, and then it often occurs before a penetrating injury, often also in farmers, people who work a lot more outdoors. And the diagnosis is through the characteristic presentation, histopathology, and then fungal cultures. And the treatment is usually with long-term, again, because it's a deep mycosis, long-term antibiotic and antifungals like itraconazole. And we may also combine that with antibiotics depending on if there is, secondary bacterial infection. Next slide. Yours is another skin NTD that it's hopefully on the verge of eradication in a lot of places, but we still have pockets of yours in West Africa and Oceania. The endemic trypanematosis, yours is caused by Treponema pallidum subspecies Pertenue. There's also the Burgel and Pinta. They're not so commonly seen, but we do still have cases, pockets of cases. Transmission is not very certain, but it's likely to be a direct skin-to-skin contact. There haven't been any known vectors or any other modes of transmission. And it mainly causes these very extensive ulcerations on the skin and may be difficult to tell it apart from other kinds of ulcerations without testing. So a lot of cases that were thought to be yours, by the time they were tested, they found it was not yours. So the serological test helps to confirm the diagnosis of yours, and this can be done on the field. Treatment is with azithromycin, and hopefully in many countries they're reporting very lower cases, and we're hoping for instance, in Nigeria, for us to say we don't have it anymore. Next slide, please. As they haven't reported any cases in a while. So next slide, please. I think I need to move a bit faster so we can keep to time.
Okay.
Prof, are you there or you want to share? So yeah. So I just tried to have an overview of some of the skin NTDs and some of our clinical experience and what we see. It's be difficult to go into detail with all of them, but we find that the challenge with controlling skin NTDs is poor access to healthcare. In many parts of the world, people cannot diagnose skin NTDs, and so this leads to late or misdiagnosis or lack of diagnosis. As we know, there are just 0 to 3 dermatologists per million people in most of sub-Saharan Africa, and most of these dermatologists are in urban areas. So, and community health workers have limited knowledge of skin NTDs and even skin diseases in general. We believe that teledermatology is something that can help to bridge this care gap that exists and can be useful in managing skin NTDs. Next slide, please. So teledermatology is just, as we know, we can use it for various means. It's with skin NTDs, virtual health worker training, and you can have synchronous real-time consultations, asynchronous or store and forward teledemoscopy, and enhancement of data collection, disease notification, and surveillance. These are all ways in which teledermatology can be useful with skin NTDs. Next slide, please. And so just give an experience of what we were able to do last 2 years with some form of teledermatology and skin NTDs. Next slide, please. So there was a virtual training of health workers of skin NTDs program, which was funded by the Dermlink grant in 2022, a project of the Nigerian Association of Dermatologists, and was supported by the ILDS and IFD. And we had bi-monthly virtual webinars on skin NTDs for primary care workers for 6 months, and it was facilitated by dermatologists and public health physicians. And the training was on clinical diagnosis, management, referral, and public health reporting of skin NTDs. Next slide, please. And during the course of this training, we were able to train and teach over 500 primary care providers, general medical practitioners, community nurses, community health workers, pharmacists, and we were able to introduce the use of the WHO Skin NTD app for NTD reporting, and also the Open WHO platform for further knowledge on NTDs to all the people. We had over 1,000 people who registered for the course, and about half of them who were able to continue with the course. We also developed a mobile app for teledermatology and NTD reporting, which was quite helpful for people at the primary care level. Next slide, please. So they were able to send in photographs to people, to dermatologists, when they were not sure about a case, and it was quite useful. So these are just pictures of the webinars, which were very well attended, and we were able to give very good lectures to the health workers on the various skin NTDs, and also introduce them to the NTD, Open WHO NTD channel. Next slide, please. We developed an app which they could send in photographs to, and they did, we had a few health workers who were constantly sending in photographs from the field, and they could get like a dermatologist to look at the photographs and say, oh, this is a good, this is what I think it is, or this looks like scabies, and how to refer, and the basic simple things like atopic dermatitis, how to treat in the community. So this denser platform has been very helpful. The challenge we had, of course, was having dermatologists have time to look at the pictures, but it's something that I think is quite promising to be able to use at the community level. Next slide, please. So in conclusion, skin NTDs are prevalent in undeserved and rural communities in Africa, and they cause, of course, significant morbidity, as we can see. They usually do cause mortality, but they do affect quality of life in a very enormous way, and prevent people from having, the socioeconomic ability to sustain themselves. So it further worsens the cycle of poverty in those communities. And the management of skin NTDs is hindered by the access to dermatological care in many cases. So teledermatology, we feel, is a valuable tool that can aid in the control of skin NTDs. And of course, capacity building of health workers will help to improve the integrated approach which the WHO is trying to push for skin NTDs management and surveillance. And dermatologists are needed for this to be successful. So that's presentation. I'd like to thank the ILDS for sponsoring that program, which was very successful. The International Foundation of Dermatology, the Nigerian Association of Dermatologists, and of course, I thank the GloDerm Training Committee for inviting us to talk about this as part of the session. Thank you very much, everyone, for listening, and I hope we have enough time for a few to answer some of the questions that we have. Thank you.
Thank you, Colleen.
Hello, everyone. I'll go through some questions. They've been posted, the one which have been answered, and the one, if we have a lot of time, Professor Wendy and Olufolakemi can answer the one which has not been answered. The first question, have you found a clinical utility in doing culture while treating Madura foot? Yes, the current gold standard for diagnosis of mycetoma is culture and PCR. Another question, is there a role for cryotherapy in management of cutaneous leishmaniasis? Our study from Ethiopia, which is published, showed that for localized cutaneous leishmaniasis, cryotherapy is optional of the treatment with higher cure rate. Another question, you organize training courses on NTDs? The GloDerm community, our course or presentation focus on skin disease, including skin NTD. Another question for consequences, annual MDA, it's been administered 10 to 15 years in endemic areas. is recommended. However, achievable and sustainable has that been? The answer is the multi-drug administration of IVM is an integrated approach with the leishmaniasis or onchocerciasis, and the current LF, and the current recommendation is 5 years, and then you monitor.
Yes.
And the cause for NTDs in Africa, the WHO has repository codes on NTDs. I'm giving the questions, and Professor Wendy can reply upon. In this era of vaccine hesitance and increasing incidence of the skin NTDs in urban areas, how would you roll out mass drug administration in urban areas? Professor Wendy.
Yeah, currently, actually, we have the experience, especially on the skin NTDs mass drug administration for the rural area. For the urban area, a bit it's challenging, as you have said it. And from our experience, especially in general in NTDs, especially STH and schisto, usually the coverage, even in Ethiopia, for the rural area much higher than the coverage in especially school deworming in urban area. So it's going to be challenging, especially in to administer mass drug administration in urban area.
Okay, thank you, Professor Wendy. Drug resistance is growing concern in the infectious disease sector. What are the emerging patterns for skin NTDs?
I think when it comes to drug resistance, for skin NTDs, the most common drug we are using now is ivermectin. So far, there are some veterinary reports from the veterinary medicine for ivermectin resistant, but no drug resistance has been reported for use of ivermectin in human. But the most important thing I would like to actually stress here is, especially when we are thinking of integrated skin NTD treatment, is also decentralizing skin disease treatments. Is especially I would like to really flag about the resistance in antifungal treatments. Most of the, even though fungal diseases, especially superficial fungal diseases, are not categorized as skin NTDs. They are skin disease of the poor. And currently, you know that there is a large incidence of prevalence of drug resistance for antifungal in especially dermatophytosis. And for the other drugs, so far we know, especially in mass drug administration, also we have doxycycline mentioned. There is no much report of resistance developed. Thank you.
Thank you, Professor Wendy. There's another request for the slide presentation. Another question.
I think the record is going to be shared. The record is going to be shared. So that's the record of this webinar will be shared.
Thank you so much, Professor Wendy. Dr. Cole, you can help us answer other questions. Just thinking loud, in the scabies, you can give ivermectin routinely or after other treatment failed, like BB or permethrin.
Well, I personally think it depends on the clinical picture. So the treatment is meant to be, start with the first line treatment, which is permethrin, or the benzobenzoate. I don't like benzobenzoate because it's so irritating. So permethrin, but benzobenzoate is more affordable. In many cases, if permethrin is not available, I think using ivermectin can be an option to give that as first line if you cannot get access to permethrin. Permethrin tends to be not so available in some resource poor settings. And benzobenzoate is not very tolerable by a lot of people. But I mean, if that's the only thing you have, you can give. So ideally should be permethrin and then give ivermectin later, but some studies are now putting ivermectin as, you start first line with ivermectin, 2 doses, and that's has up to 95% success rate in treatment. So I would say it also depends on situation. If it's crusted scabies or it's quite severe, I would say go for ivermectin, in conjunction with topicals as well.
Thank you,
So
Dr.
ivermectin, from our experience, we use it more, especially ivermectin is essential on when there is a community management and mass drug administration. From Ethiopian experience, we are using ivermectin, especially when you have the prevalence. That's also now the WHO recommendation. When the community prevalence is greater than 10%, ivermectin administration for those who are indicated. Mass drug administration is very much essential, because when you are treating the community, it's really difficult to demonstrate the application of topical drugs. And even though those topical drugs, ivermectin and permethrin, they are much more equivalent in their efficacy. But when it comes to applicability, the oral treatment is much more easy to use in the community-based treatment.
Yeah. Yes.
There's more questions regarding duration of mucocutaneous leishmaniasis treatment with sodium dichlorgluconate. The duration.
Yes, for duration of mucocutaneous. Well, usually you want to treat in many cases for 2 to 3 weeks, I think. For visceral leishmaniasis is usually recommended to treat for 28 days. It's given IV or IM. With mucocutaneous leishmaniasis, depending on the severity, you can give for 21 to 28 days as well. That's typically what is recommended.
Thank you. Does Glodam also have resources to learn more about skin NTDs endemic in Eastern Indonesia, Archipelago, West Papua, Maluku, and other Pacific islands?
Yes,
I think there is a lot of resources in the WHO repositories,
the
training
WHO
repositories. And
yes.
You can access in most of the skin entities. We have resources in the WHO repositories.
Yes. So the WHO channel, let me see if I can put that on the slide, on the chat. But it's really resourceful for the open WHO channel for skin NTDs, and it's a fantastic resource for learning.
And when do we recommend limb amputation for Madura patients?
The Madu in the mycetoma, especially the actinomycetoma, is a bit responsive for the combination of the antibiotic treatments. But the fungal or the EU mycetoma, just the treatment duration is long. And also, one of the most important things is, especially in most of the cases of mycetomas, the systemic treatment has to be really given with a surgical option. There has to be a surgical debridement. And the other most important thing is also the currently available drug, especially itraconazole. It's even in a clinical trial, its efficacy is around 70%. Some of the patients, especially if they're not going to get adjuvant surgical intervention, they may end up having a destructive Madura, which involved not only the skin, but also the bones. At this time, at the last option, an amputation can be recommended.
I think we're running out of time. I can read one more question. Most of NTDs cause stigma and patients tend to remain in the villages stigmatized. What is done to approach these patients who are stigmatized and sometimes with no financial capacity to consult dermatologists who are still few and mainly based in cities?
You are muted, Ole. You are muted.
Okay, sorry. Well, I was saying that I think the stigma is first we need to address that with health workers and realize that there is no need to stigmatize people with NTDs. A lot of them are not very infectious, like if you're in close contact with them, and you don't have to like try to avoid I would say going close to patients, because I think it starts from the health workers and then families as well. So I think we need a lot more education of health workers of the community that, a lot of these conditions can be adequately treated or treated early. And if they're treated, the person can be cured in most cases. So there is really no need for stigmatization. And of course, with the financial capacity, that's the reason why there are so many programs for free treatment, mass drug administration, and things like leprosy and really ulcer, where the treatment is free. And the MDAs also, the treatment is free. In many cases, for the treatment for NTDs, the treatment is free. Well, a few skin NTDs, the treatment is not yet free, but they're working on getting access to care for people who really need it. So I think that can be helpful. And then the teledermatology is a helpful thing. And we need a lot more dermatologists to volunteer their time for community dermatology outreaches and for teledermatology for rural communities. If we can get more dermatologists to get involved with that, so even though they're in the cities, they can support health workers in rural areas through teledermatology, that can help with the financial burden of, consultations with dermatologists.
Okay. Why most of the skin diseases so-called neglected? Who neglected? Minister of Health or community neglected it? What will be our recommendation for the community and ministry?
I can jump.
This
Okay.
question I'm trying to understand.
Yeah, it's the neglected tropical diseases. And sometimes we can, well, they're so-called neglected because they're neglected by the policymakers, the scientists, and the physicians. And that's one thing. And they're labeled, grouped as a neglected tropical disease, actually to give an emphasis for WHO. That's why how they're grouped there. But the name is a bit a misnomer. We have published one study actually to say in Ethiopian setting, actually we have a different name for neglected tropical disease. We call it's a disease of the neglected people. So practically it's the available option name we have, but it's not the perfect name when we say neglected tropical disease. Thank you.
The last
Yes,
is
okay, go ahead.
It's the last one. Is there an online course for NTDs?
Well, that's just the WHO course will be, that's just for NTDs, the WHO course is the important report step. Thank you.
Thank you.
Thank you very much. I hope it was helpful.
Right. Thank you everyone for attending, and thank you very much to Prof. Wende and Dr. Olufolakemi for your very insightful presentation. I think we've all learned a lot, and even from the chat box, you can see everyone is very appreciative of the presentations. I don't know how people can reach you in case they have any other questions for you, but we are very grateful. So thank you, and you can follow GLODAM on social media to learn about upcoming events, webinars, programs, and more. So
Thank you very much.